Welcome to cardiovascular assessment. This body system comprises of the heart, of course, but also the peripheral vascular system. So we're going to focus on assessing the heart, peripheral pulses, capillary refill, and the neurovascular status of the extremities. Here's another body system that affects and is affected by other body systems. Honestly, you can't discuss the lungs without discussing the heart and vice versa because they're physically connected and we shouldn't be assessing one without assessing the other. Like I've already said, the cardiac system affects so many other body systems, so we have a lot of questions to ask in our interview. I'll mention some here, but just know there are many more we can ask that we're going to discuss in our cardiac lecture later on. We want to assess about any chest pain, just like with the lungs. And if they say yes to this question, we're going to stop here and we're going to focus on their chest pain. We also want to ask about any leg pain, sleeping issues, diet and exercise, any swelling in their hands and feet, any medications that they take, any past medical history they may have, or any family medical history related to the heart. Many cardiac diseases are familial, so family history is important. And we also want to ask them if they notice any swelling, tenderness, or redness anywhere in their body. When we inspect the cardiovascular system, there are actually several places that we need to inspect. In addition to the sclera and mucous membranes and looking at the color and moisture to make sure that they are receiving blood supply and oxygen, we need to assess the chest and heart and the upper extremities and the lower extremities. When we inspect the heart and chest, we're looking at skin color, but we're also looking for any heaving of the chest wall. Heaving is when the chest is raising and lowering with each heartbeat. Typically, we don't see heaving unless the person's very skinny. So if we see it in an adult and they're not very skinny, it may be abnormal. It's caused by very forceful ventricular contractions during systole. So it may mean that their heart is beating really, really, really hard, and it may be having a hard time to push the blood out. When we inspect the upper extremities, we're looking at the color of the skin, especially the fingertips and nail beds. We also want to look for edema and swelling in the upper extremities. We want to do the exact same thing for the feet and toes. It is more common to have edema in the feet and ankles, so we really need to inspect for that. We also inspect the legs for any ulcers on their feet, ankles, and lower legs, as well as any color changes and temperature and texture changes to the lower leg skin. Checking the temperature of the upper and lower extremities, along with moisture, is very important. The skin on the extremities should be warm if they're getting enough blood supply, so if they're cold, we need to be concerned that they're not getting the blood and oxygen they need. When we assess the extremities for temperature, we're going to use the dorsum surface of our hands, and we're going to assess both extremities at the same time. So both arms at the same time, both legs at the same time. This way we can feel both sides to make sure they're equally warm. And just as an FYI, the feet are usually a smidgen cooler than the upper extremities just because the feet are the furthest away from the heart. I'm not saying they're cold, I'm just saying that they're usually just a bit cooler. We can also tell moisture of the extremities while we're assessing the temperature. Remember, skin should be warm and dry. This is also a great time to look at the color of the extremities and look for any swelling or redness. We also discussed skin turgor with integumentary, and skin turgor is a good indicator of fluid status, which is a cardiac function, so I'm going to discuss it here again. When we check skin turgor, we should be assessing on the inside of the forearm or on the chest just beneath the clavicle. We gently pinch the skin, and if it goes back flat, or if it stays in a pinched position, we're going to see what's going on. Tenting is when that skin stays pinched and does not go flat, and it usually means the person does not have enough fluid in their body and their skin is dehydrated. When we're assessing pulses during a physical assessment, we're doing more than counting them like we do for vital signs. For health assessment, we're assessing for the presence of the pulse, the strength, and the amplitude. Normally, we assess radial pulses, posterior tibialis, and dorsalis pedis. If our patient doesn't have one of those, maybe due to an amputation, then we're going to move to the next closest pulse. We don't routinely check the carotid pulse as we don't want to occlude blood flow to the head, and we really use that pulse for emergency situations. When we are assessing for pulses presence, we assess both pulses at the same time so we can compare the presence and strength simultaneously. Same with the post-tibial and the pedal pulses. We do them at the same time. We also assess for amplitude of the pulse. Is it bounding, like it's beating really, really hard, or is it thready and hard to feel? What is the quality? Is it strong and easily felt, or is it weak and hard to feel? We check the rhythm. Is it coming exactly on beat, like every single time, like a metronome playing, or is it irregular and coming whenever it feels like? When we assess how strong pulses are, or the amplitude, we use grades to discuss the strength. A grade 0 means we feel no pulse. There may very well be a pulse and the patient may very well be alive, but we cannot feel that specific pulse location. A grade +1 pulse means the pulse is weaker than normal. A grade 2 plus pulse is normal and strong, and that's exactly what we expect it to feel like. A grade +3 pulse means it's very strong and bounding, maybe too strong. A word of caution though, some electronic medical records have a grading scale that goes from 0 to 4, making a +2 to +3 their normal ranges, so make sure you know what you are charting based on the system that you use at your job. We discussed capillary refill a little bit in integumentary, but we're going to discuss it here a little bit more. Capillary refill is a way for us to figure out how fast it takes for blood to refill in the capillaries. To do this, we use our fingers and we press gently on the nails enough to make the nail bed turn white. When we release our fingers, we count how long it takes for the nail beds to go back to their normal pink color. A normal capillary refill time is less than 3 seconds. Any longer than that could mean there's decreased circulation in the body. We check capillary refill on every finger and every toe. If they have nail polish on, we're going to do the same thing, but on the sides of their finger. And you can check capillary refill pretty much on skin all over the body. It doesn't have to be the fingers and toes. We just choose those because they're the furthest away from the heart. While we're palpating the extremities, we also need to palpate for edema. Edema is swelling from fluid in the tissues. We'll talk more about edema in the musculoskeletal lecture and the fluid and electrolytes lecture, but normal, healthy extremities do not have any edema. When we press on the lower extremities, especially the malleoli or the little ankle bones, we should not feel any squishing swelling. If we are able to feel some squish, this is edema. The first picture on the left is a picture of the different grades of edema. The deeper we can squish our fingers into the edema, the higher the grade. 0 edema would be normal, no edema present. A +1 edema would mean that we can squish a little bit, about 2 millimeters deep. +2 edema means we can squish about 4 millimeters deep. +3 means we can squish about 6 millimeters deep. And +4 means we can squish 8 millimeters or deeper. If our fingerprints stay in edema, like the picture on the right, we call this pitting edema. Neurovascular checks can technically be part of the musculoskeletal system and or the neuro system, but we do the check at the same time we check pulses and cap refill, so I'm going to include it here. When we check the neurovascular functions, we're checking each extremity for grip strength, pushes and pull strength, and asking if the patient has any numbness or tingling in their fingers or toes. We also have them wiggle their fingers and toes to make sure they can move them, as well as checking to make sure they have sensation in their feet. When we check grips, pushes, and pulls, we're checking both extremities at the same time. So have them squeeze both hands at once, push both arms at once, pull both arms at once. This way you can see if both sides are equally as strong, and you're going to do the same thing with the lower extremities. If the patient doesn't have the exact same strength in both sides, something is wrong. Auscultating heart sounds really means we're listening to the sounds the heart makes when the cardiac valves close. The closure of the valves make the noises we hear. We want the patient to breathe normally while we listen to the 4 locations of the heart with our stethoscope. We first listen to the heart with the diaphragm of our stethoscope, starting at the aortic area at the second intercostal space on the right sternal border. Then we move to the pulmonic area at the second intercostal space on the left sternal border. Then we move down one rib cage to the Erb's point, which is the third intercostal space on the left sternal border. Then we move down to the tricuspid area at the fourth intercostal space, left sternal border. And lastly, we move down and laterally to the mitral/apical location, which is the fifth intercostal space at the mid-clavicular line. If we see a heave that we mentioned earlier, this is going to be the spot that we would most likely see it. This is also the spot we use when we need to count the heart rate. We call the heart rate at this location the apical heart rate or the apical pulse, and we use that apical pulse for things like giving medications that are going to affect the heart rate and blood pressure. If you remember anatomy and physiology, you'll guess that these locations we listen to aren't where the actual valves live. This is just the area on the chest where we can hear those valves the best. If you want to remember these locations, here's a little mnemonic you use. This is the one that I learned in nursing school a long time ago, and I still use it. It is ape to man. So aortic, pulmonic, Erb's point, tricuspid, mitral. On the slide, there's two other ones, but ape to man is what my brain has remembered. Then we're going to repeat this entire thing all over again using the bell of our stethoscope. And the reason that we use both sides of our stethoscope is because the heart has different tones of sounds, and we may miss abnormal sounds if we only use the diaphragm. Now that we know how to listen to the heart tones, what are we actually listening to? Well, like I said, we're listening to the valves close. There are 4 valves in the heart, and they close in sets. The first set of valves closing are the mitral and tricuspid valves, and they close at the start of systole. This is the lub that we hear, or S1. The second set of valves to close is the aortic and pulmonic valve, and this is the end of systole, the beginning of diastole, and this is the dub sound we hear, or S2. Each heartbeat is lub-dub, meaning when we hear lub-dub, that is 1 heartbeat. So lub-dub 1, okay? There are 2 extra heart sounds we hear that are abnormal. There's an S3 sound that indicates fluid overload inside the heart. If somebody has an S3 sound, it may sound like lub-dub-D, lub-dub-D, lub-dub-D when we listen to their heart sounds. The other abnormal sound we can hear is S4, which is going to sound like D-lub-dub, 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 and we also call that an atrial gallop. This is usually heard when the heart doesn't squeeze very well from valve issues or muscle issues. Those are higher level block topics. We do not talk about anything S3, S4 related, other than in heart failure, we may discuss S3 for fluid overload. And then lastly, the S1, S2 sound can have variations, and those are called murmurs. Murmurs are not block 1 content, but if you hear an S1, S2 sound that sounds swishy and not crisp, that's probably a murmur, and it indicates that a valve is not closing properly. Just like with the thorax and lungs, there are common variations in the cardiac system that occur with older adults. First, it may be hard to hear the apical pulse. It may be difficult to palpate peripheral pulses as the heart doesn't beat as strong as it does in younger adults. This means we may also have slower capillary refill and cooler extremities. Older adults also have less elasticity of their skin, so their skin may tent just because the skin is less elastic. For older adults, I prefer to check skin turgor under their clavicle rather than on their forearm, and never, ever, ever check a skin turgor on an older adult's hand. It's always going to tent no matter what. And this is the end of part 6, the cardiovascular assessment.